Our next presenters are Karen Heinsch and Dr. Laura Gelfman. So Karen Heinsch is the clinical lead for the supportive cardiology program at Mount Sinai Hospital. She's embedded in the heart failure team and provides palliative care to cardiac patients. In this capacity, she is focused on moving palliative care upstream for heart failure, LVAD, and ECMO patients. She developed a protocol for LVAD deactivation, implemented a trigger-based palliative care screening initiative for the cardiac ICU, and expanded training for palliative care fellows and NP students on topics in cardiology and LVAD. Prior to this role, she was a primary care provider at the Mount Sinai Peak Health Program, providing intensive primary care in the clinic and at home to medically fragile patients at high risk for hospital readmission. She received her BSN and MSN in adult and geriatric health with a subspecialty in palliative care at Columbia University School of Nursing. And we also have Dr. Gelfman, and she received her medical degree from Mount Sinai School of Medicine and then completed her residency in internal medicine at New York Presbyterian Weill Cornell Medical Center. She then completed a clinical fellowship and research fellowship in hospice and palliative medicine at Mount Sinai Medical Center. She also completed a master's in public health degree to enhance her research skills. Dr. Gelfman is board certified in internal medicine and hospice and palliative medicine. She's currently a professor and vice chair of quality and clinical innovation in the Brookdale Department of Geriatrics and Palliative Medicine at Mount Sinai. She's additionally a palliative medicine clinician who teaches aspects of palliative medicine, symptom management, and communication. Her overall career goal is to create a body of research that will improve palliative care delivery models for patients with serious illness, in particular cancer and heart failure. Thank you guys so much for joining us.
Thank you, Lauren. We're thrilled to be here. I'll first just quickly introduce myself. I'm Laura, and Karen, if you want to say hi.
Hi, I'm Karen.
I'm going to start us off, and then we'll hand it over to Karen. Karen is truly the one who is incredibly knowledgeable about the delivery of care for these patients, and I get to do a lot of quality improvement and research in this population. So to get us started and sort of making sure that we're all on the same page, I want to, well, first before anything, really want to acknowledge that a lot of the work that we are sharing, stands on the shoulders of our palliative care clinical team, as well as our advanced heart failure clinical team. And we're very fortunate to have such a robust collaboration between these two services. Our three objectives for the next 40 minutes or so is to review the spectrum of palliative care for patients with heart failure, to then describe briefly the current evidence base for palliative care for patients with heart failure, and then finally think about ways in which we can integrate both primary and specialty palliative care for patients with heart failure. So again, getting us on the same page, we want to just think about what is palliative care broadly, thinking about specialized medical care for people with serious illness with the goal to improve quality of life for both the patient and family, is provided by doctors, nurses, social workers, and other specialists who work with the patient's other doctors, in this case, often cardiologists or internists, to provide an additional layer of support. And what we, often need to remind our cardiology colleagues is that it's really appropriate at any age or any stage in a serious illness, and can be provided alongside our curative and disease-directed therapies. And as you'll learn more, Karen's work is really emblematic of that. So what is advanced heart failure? The ACC, or American College of Cardiology, and the American Heart Failure Association define stage D heart failure as patients with persistently severe symptoms despite maximal guideline-directed medical therapy. And in this graphic on the right, you'll see that there is really a intersection of the American major cardiology societies, as well as the Heart Failure Society of America and the European Society of Cardiology, coming together when looking at sort of where's the overlap between their distinct definitions of heart failure. And really, this actually is emblematic of sort of where palliative care comes in the care of these patients. So across all these definitions, patients with advanced or end-stage heart failure have severe symptoms, have already been on optimal medical therapy, often have recurrent hospitalizations and severe functional impairment. And so that's often sort of the signpost for us of when to get involved. It's not so much about filling pressures and VO2s and all, sort of fancier, higher tech assessments, but really thinking about symptoms, hospitalizations, and functional impairment. Patients with heart failure live with a whole panoply of symptoms. As you see here, this is work done that's a while back, just demonstrating among patients with heart failure the burden of symptoms that they carry, and often symptoms that we may not screen for. So the symptoms, the list of symptoms is long, and I think the key that we really want to share with you here is that the best management for these symptoms is the management of heart failure itself. Of course, we have other tools in our toolbox to help manage some symptoms after, the heart failure management has been optimized, where we come in and may have to help with things like anxiety, depression, and insomnia. But really the first line is addressing heart failure itself. For patients living with heart failure, the estimated one with end-stage heart failure is 1 year survival is 52%. So it's really important to remember that there's a worse prognosis than many cancers for some of these patients. When you look at the median survival among patients who are newly admitted with heart failure, it's only 1.8 years. And then in this work done by Joe Rogers, looking at patients who over time at their lifetime number of hospitalizations and survival, you can also see that 61% of patients were readmitted for heart failure within that first year. So their survival is short and they're often brought back to the hospital. We also know from some older data that is still salient is that with each subsequent hospitalization, there's an increased risk of mortality. And so looking at all comers who don't even have any chronic kidney disease, looking at all ages, the median survival after the first heart failure hospitalization was 2.4 years. Yet when you start looking at the second, it drops to 1.4 years, the third to 1 year, and finally the fourth to 0.6 years. And that's only significantly decreased when you're looking at patients with chronic kidney disease in addition to their heart failure or among the older and oldest old adults. What we also know is that heart failure doesn't sit in isolation. You're here learning a lot about different geriatric syndromes, and we know that people with heart failure often don't have heart failure alone, but are living with frailty. They may have dementia. They may have other organ failure, multimorbidity, and so really, these patients are sitting not with heart failure alone. And unlike cancer, although this trajectory is certainly changing dramatically with the advent of different immunotherapies, patients who with cancer who are approaching the end of life often have a significant decline in their function. Whereas with patients with heart failure, there's a lot of uncertainty where with each heart failure exacerbation, they may have a decline in their functional status, yet with appropriate heart failure directed therapies, they may regain function close to their prior baseline. Yet it's very hard to predict sort of where patients are along in their trajectory, which creates a lot of uncertainty for both patients themselves and us as clinicians. Furthermore, we've created a lot of amazing therapies, which have really sort of stretched the trajectory where patients are able to sort of almost like go backwards in time along their clinical trajectory, from things like improved survival from myocardial infarction, improved survival from heart failure itself. And what this is going to result in is that there are projections of more than 8 million people 8 million adults with heart failure by 2030. So this is a ever-growing population, yet the treatments have grown increasingly complex. It's no longer quite as simple as this gentleman seeing his cardiologist saying, "I'm taking better care of my heart. I've started using aspirin as one of my pizza toppings." Now we can replace the heart, we can remodel the heart, we can reprogram the heart, we can repair the heart. And so with all these treatments, we're able to sort of change the what was previously a trajectory, and we've added sort of be able to bring people back, regaining physical function, improving quality of life and survival. Yet with that comes a significant amount of further uncertainty. So with all this, many of the primary, the significant cardiology societies are promoting palliative care, particularly for patients with advanced heart failure. Yet what we know is patients with heart failure are less likely to receive palliative care. In this study led by Hyder Warwick, they're looking at the percentage of patients with cardiovascular disease who received hospice is in the blue line. So we're certainly making strides, yet that line is far below the percentage of people who died from cancer who received hospice, which is the red line. So we have a lot of work to do in terms of recognition of the patients who are both eligible for hospice and who may benefit from it. Here, we also know that patients with heart failure are often less likely to die at home as compared to patients with cancer. And you can see that in here, when looking at the medical facility, 34% of patients with cardiovascular disease die in the hospital, whereas only 22% of cancer. More patients with cancer are able to die at home, and more certainly on hospice. And so again, there's opportunity there. So what's the evidence for palliative care for patients with heart failure? It's a growing area of interest in evidence-based growing for the benefits of palliative care with heart failure. Yet often, it's a different model than we use potentially for models like cancer. And what we know is that oftentimes patients with heart failure are not aware of how sick they may be. In a study where we looked at a subgroup analysis of a trial called the Wisdom trial of patients with heart failure, advanced heart failure, who had a defibrillator, who are at high risk for death. We found that although 78% of them were aware that they could die from their heart failure, only 26% had discussed their end-of-life preferences with their physician. So while people may be increasingly aware of their illness, the priorities and preferences for treatments are not actually happening in terms of conversations. We also know that there's a big gap between patient sense of what their prognosis is and what their clinician sense of prognosis is. So using a same data set of looking at 272 patients, the clinicians who estimated their prognosis to be less than 1 year, only 7% of patients had the same estimate. So there was really more likely to have lack of concordance between the clinicians and the patients among patients who had a lower symptom burden, both in number and severity, and those who did not have an advance directive. So there's still a large gap there where patients and clinicians are not on the same page in terms of prognosis. So how can we put some of this evidence into practice? And this is where I will turn it over to Karen.
Thank you, Laura. So what does this look like in practice? I'm going to start with a case study. Mr. J is an 82-year-old man with a history of ischemic cardiomyopathy, an ejection fraction of 20%, type 2 diabetes, CKD stage 3, and hypertension. He lives alone in a rent-stabilized apartment. He has a daughter who works full-time, has young children, and lives an hour away. In the past year, he has had 5 heart failure admissions. And before each admission, he's had a period of increasing shortness of breath, volume overload, and functional decline. It's been getting harder and harder for him to do what he needs to do. And he is on guideline-directed medical therapy, but he still has New York Heart Association Class 4 symptoms: dyspnea at rest, orthopnea requiring 3 pillows, and profound fatigue. 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . 2 . In terms of quality of life, he is often feeling too tired or short of breath to be able to do basic things like cleaning, grocery shopping, or cooking. So he's ordering a lot of takeout and preparing frozen entrees, which are high salt, of course. He's overwhelmed with his medications, which get adjusted at every admission, and he's often kind of confused about which ones he should be taking. He's not sleeping well. He's having difficulty laying flat, and also he's up at night urinating frequently because he takes his Lasix right before bedtime. He is no longer able to do most of the things that he enjoys or used to enjoy, like poker nights or coffee with friends. He's worried about going back to the hospital. His mood is down, and his daughter is getting more and more worried about him, his safety, and she's trying to balance caring for him with her job and her family responsibilities. Whenever she is able to visit him, which is about once a week, she spends the time cleaning his apartment, making sure he has groceries, and not a lot of time visiting with him. So how could palliative care help in this situation? So let's say on one admission, somebody recognizes that a palliative care consult is warranted in this situation. I think we would start by looking at his symptoms and seeing what we could do to help alleviate his symptoms. So tailoring his diuretic regimen together with the cardiology team to really focus on comfort, adding some low-dose opioids for dyspnea, supportive care for his fatigue, his insomnia, and poor appetite. Having a family meeting so we can discuss the disease trajectory and really kind of get to know what his values are and what's important to him, and do some advanced care planning. Looping in social work to address some of the issues that, for example, the food that he's struggling with, and exploring options for home care as well. Coordinating with pharmacy to simplify his medication regimen. Care coordination, making sure that he's got some early follow-up, and working on things to prevent admissions like home-based palliative care. And then offering some emotional and psychosocial support, addressing the fear and isolation and the mood, and offering support for his caregiver as well, his daughter. Really coming up with a plan that's aligned with his values. So what does it look like to set goals with a patient like this who's got advanced heart failure? So in palliative care, we always kind of start with asking permission to have a conversation. Is it okay if we talk about your heart disease and what it means for your overall health? Then find out what they know, right? What has the medical team told you about your heart failure? And in general, just sort of focusing on what's important to him and what his goals are, rather than focusing on treatments. So based on what you've heard so far, what is most important to you? What worries you? A lot of times you'll hear from patients that being able to interact with their loved ones is meaningful and important for them, being free of pain, spending time outside the hospital, and sometimes living as long as possible. And I think it's important to just recognize that, you may not always agree with what the patient's goals are, but once you have kind of figured out what their values are, then you can make some treatment recommendations aligned with those goals. So would it be okay if I make some recommendations based on what you have shared with me? So for Mr. J, in terms of symptom management, what happens during the palliative care consult, with close coordination with cardiology, we adjust the diuretic so he's not taking his Lasix just before bedtime, which minimizes his nocturia and helps him sleep better. Adding a low-dose opioid as needed for shortness of breath, and helping him sort of prioritize the activities that he values the most. For example, if he wants to go to coffee with friends, he's up early anyway, go at 7 or 8 a.m., have coffee with your friends, and then later take your Lasix when you get home. Goals of care, sharing that his heart failure is progressive. He's likely to get sicker. And, having an understanding of that, the patient was able to share that he doesn't want to keep coming back to the hospital as much, and he wants to be able to see his grandchildren more. Social worker referred for low sodium meal delivery service like Meals on Wheels. So he's eating less salt and he's spending less time struggling to get himself fed. Referred for home care for help with the cleaning and the shopping and laundry, so his daughter doesn't have to worry about that as much. In terms of care coordination, making sure he's got that rapid follow-up appointment with cardiology within a week of discharge to check in on his symptoms and to make sure he's taking his medications correctly. Setting him up with blister pack medications at a pharmacy so he is not confused about what he should be taking. And referring for a home-based palliative care program so they can continue to follow him as his symptoms progress. In terms of support, met with the chaplain, was able to share his worries with the team and with his daughter, and had a meaningful session with our music therapist. So what does this look like in terms of impact on his life? Well, he's sleeping better. He is less overwhelmed with his medications. There's less shortness of breath. He is meeting his friends weekly for coffee. And when his daughter visits, she's able to, focus not just on the laundry and the cleaning, but she's able to bring her kids, and they're able to have a more meaningful visit than when she was bogged down with taking care of all those responsibilities. So reduced caregiver burden, improved quality of life, and decisions that are really aligned with his goals. So who is it that should receive palliative care and when? So looking at this here, I think it's really clear that stage D heart failure, we've got refractory end stage heart failure. These patients should absolutely be receiving palliative care, and that is like Mr. J. People who are sort of pre-stage D, they've got symptomatic heart failure, but not necessarily symptoms at rest, could be helpful. And stage C, those who have known structural heart disease, some shortness of breath and fatigue, and reduced exercise tolerance, it's less likely, but certainly could benefit from these conversations. So I like to look at this sort of to differentiate the traditional heart failure management, what can be happening by the primary clinician, whether that's a primary care provider, a geriatrician, or a cardiologist, and then when specialty pal care should get involved. So the traditional heart failure management, you're starting with assessments, history, exam, diagnostics, and at the same time, ideally, the clinician is controlling pain and other symptoms and starting to assist with decision-making and advanced care planning as you are predicting and communicating the prognosis to the patient. When you're choosing therapy, also thinking about assessing and reducing the emotional distress and the burden to the patient and families, managing trigger events as they come up, and monitoring their physical function as their quality of life declines, making sure always to coordinate across the patient's care team and promote quality of life for the patient and caregiver. When the problems are especially complex or severe, then it's time to call in specialty palliative care, including hospice. Why is this so hard? As Laura explained, it's not always happening or not happening as often as it should be for heart failure patients. Well, this study here shows that a lot of heart failure patients have poor self-rated knowledge about self-care behaviors. So looking at this, a very high percentage of patients, it's like nearly 80% of patients with advanced heart failure are not at all sure what to do when their heart failure symptoms worsen. Not sure who to call, not sure what changes to make. And so you can understand why they may wind up in the ED when the symptoms are out of control. It's a very small percentage who actually are confident about what to do. And the same thing, the second part there, how well do you understand what things you're able to do to keep your heart failure symptoms from getting worse? Whether that is making sure that you take all of your medications or avoiding salt. Again, almost 75% of these patients are not sure at all. The other issue is patient perceptions of heart failure. So patients are often less likely to believe that they will die of heart failure. They often don't see it as an illness. It's not the same type of scary word as cancer. So it's more common for patients not to be as worried about their heart failure as they might be about a cancer diagnosis. And there's a variety of desires for information sharing. Some people want to have, straight information, even if it's not good news. And other people, like this quote here, if my doctor told me that my health got worse, I would walk out. They don't want to hear bad news. And from the provider side, these conversations are difficult. A lot of people do not want to give bad news. It doesn't feel good. And I think it's especially true for cardiologists who are used to saving lives. They don't like to shift and talk about the possibility that we may not be able to prolong someone's life for much longer. And there is a lot of uncertainty, especially when someone is having a lot of admissions and they bounce back. It can be hard for the clinician to step back and say, wait a second, something is changing here. It's been harder and harder to get somebody back to their baseline when they're admitted. So let's talk about hospice a little bit. So this shows that patients who actually, with heart failure, who do receive hospice actually live longer than those who get usual care. And I think that's important to keep in mind when we're discussing hospice with heart failure patients. It doesn't mean that they are giving up. They may actually have a longer life. But hospice enrollment occurs close to death. Looking at these figures here, the median number of days enrolled in hospice was 15. There's not a lot of time to have the benefit of that extra layer of support. What are the barriers to hospice use? So there are disease factors. There's a really unpredictable trajectory in heart failure as compared to some other diseases like cancer that Dr. Gelfman showed earlier, this like up and down with heart failure. There are frequent exacerbations, and the symptom burden is high. In terms of clinical factors, it can be hard to prognosticate. A lot of cardiologists are uncomfortable with palliative care, and a lot of hospice and palliative care clinicians are not well trained in heart failure cardiology. Policy factors, the 6-month survival requirement, it's less clear in heart failure to be able to say, this patient absolutely has 6 months. It's harder to figure that out. There is low payment reimbursement in hospice, and there's no concurrent care option. Other factors, a lot of patients overestimate their survival, and there's just not enough research for palliative care and heart failure. And again, integration of palliative care within cardiology is not common. This is the eligibility for heart failure. So a patient who is already optimally treated for their heart disease, and they're either not a candidate for a surgical procedure like a valve intervention, an LVAD, or heart transplant, or they decline those procedures, and somebody who has a New York Heart Association Class 4 symptoms. So that is symptoms at rest or symptoms that worsen with any activity. And then, so an ejection fraction of 20% or less is helpful to have documented, but it's not necessary. So it's not like you would have to do that if you haven't already had that done. And then the other factors here under 3 are supportive, but helpful, but they're not required. So treatment-resistant arrhythmias, a history of cardiac arrest or resuscitation, unexplained syncope, brain embolism of cardiac origin, or concomitant HIV disease. So what does hospice provide? So medications, DME, medical supplies, and counseling. In terms of other things, it really depends on the agency. So sometimes you can get thoracentesis or paracentesis covered, antibiotics, transfusions, tube feeds. For heart failure, inotropes are particularly relevant. A lot of patients on milrinone or dobutamine or dopamine at home, that is becoming increasingly difficult to find a hospice agency that will cover them. Within the past year, it's been more and more complicated to do that. But previously, I had patients on milrinone at home on hospice for a very long time. And so, you really have to, when the referrals are being made to hospice, you really have to figure out beforehand, before you walk into a family meeting, to try to figure out, are you going to be able to find an agency that will take this patient on milrinone? Or is this something that is really not going to be feasible? And so you're going to have to talk about stopping the milrinone. What does hospice not cover? So does not cover 24/7 caregiving in the home, does not cover dialysis, cancer treatments, or routine labs. And often they require a patient not to live alone. So they would need to have someone living with them, which is part of the reason that Mr. J couldn't go for home hospice and had palliative care at home instead. Common question, can a patient on hospice go to the hospital? So, I think it's important, if a patient's asking you this or a family's asking you this, you try to understand why they want to go to the hospital. Have they changed their philosophy of care? Do they not want comfort-focused care at home? Are they having like a symptom crisis and they need to go in for, expedited management of those symptoms? Have they not really understood what hospice care is? Or do they need, an evaluation for something like a fall or a fracture? Also important, I think, because this comes up a lot, that you do not have to have a DNR or DNI in order to be enrolled in hospice. But keep in mind that for an inpatient facility, often they're not able to run a code. So if you're going to an inpatient hospice, they may require you to be DNR, DNI, and even do not hospitalized. That's going to depend on the facility. But hospice enrollment and re-enrollment is voluntary. So if someone enrolls, they're able to disenroll whenever they want to, if it's not working out for them. Okay, so key opportunities. So we just don't have the workforce to have palliative care clinicians embedded in every heart failure team. And so it is very important to try to get heart failure and cardiology clinicians comfortable and trained in core palliative care skills, so that we can develop, innovative and tailored models for palliative care. So again, training the heart failure clinicians and redefine who's able to have this conversation. Registered nurses, advanced practice nurses, PAs, social workers, chaplains, community health workers, and others are all people who are important parts of the team and can have these types of conversations with the proper training and support. This is a look at our team here at Mount Sinai. Up here, well, on the left side, you've got the cardiology teams, heart failure teams, and on the right side, the Pal Care, and there I am sort of in the middle of both of them. And this is just a look at some of the data. So just sort of in summary, that when we started this program and really were embedded in the heart failure team, we were able to capture patients above and beyond what the referral-based palliative care team was seeing. So not taking away from the consult teams, but adding. So showing that we're able to capture more patients earlier in their disease trajectory, more functional than those that were being referred to the palliative care consult team. So here is just a look at sort of opportunities to integrate palliative care across the spectrum for patients with heart failure. And This shows stage D, patients who are at, stage A through C, so they're at risk for developing stage C, hopefully with a higher functional status than patients who are moving into early stage D that may be candidates for VAD or transplant. Stage D, in the middle of stage D, getting medical treatment, and then late stage D, hospice. So as their functional status is declining, they're having increasing needs, more and more opportunity to have palliative care involved. Here are some resources for you if you are interested in learning more about palliative care skills and how to apply them to patients with heart failure. That is the end of our talk. We have time for questions this year.
Thank you guys for that talk. We really appreciate it. We do have some questions in the chat. I'll start with, how do you handle AICDs and PPMs at the end of life, and how do you approach these conversations with patients and their families?
Karen, do you want to take that?
Sure. Great question. So, I think it depends on the patient. So I guess to clarify whether deactivating or implanting, but both of them, you would be making sure that you have a sense of what the patient's goals are and what's important to them, sort of in the bigger context. I think with ICD, it's important to keep in mind that there is a risk of somebody being shocked, and that sort of can be really traumatic. And I've seen a lot of PTSD in patients who have been shocked. I was actually having a conversation this morning with a geriatrician here, and she was saying she's got this older patient who has a little bit of dementia, and heart failure is recommending a defibrillator, and she's not sure. And I'm, just thinking about what happens if this man does get shocked. He's 85, he has a good quality of life now, but if he gets shocked, he can develop PTSD and may not have an awareness, even if you deactivate it, that it's off, and may continue to have that fear. Because the trauma from being shocked is quite real. But for some patients, it's absolutely the right decision. And I think it really depends on the context of what else is going on with the patient and what's important to them.
And I guess maybe can you talk a little bit about maybe a scenario where a patient is comfort care nearing the end of life and they have a pacemaker already?
They have a pacemaker already. Sometimes EP will sort of not deactivate it, but change the threshold. It's not as common as having to deal with an ICD deactivation. Anything you want to add, Laura?
Yeah, I would say usually, unless the family has a very strong feeling about it or request for it, right? It doesn't cause harm per se.
Yeah.
And so usually we let the pacemakers be. I think that for the AICDs, as Karen was alluding to, the key is ideally having that conversation up front when it's being implanted, that it can be deactivated, and then making that so that it's not the first time they're having that conversation when it's the time to consider deactivation.
Makes sense.
But I'll say it's uncommon that someone is going to address that. You're probably going to get a patient who already has an ICD. Yes. And you're going to be the first one talking to them about it. It's not like those conversations are actually happening when EP is putting it in.
Yes.
Nice idea, but less common.
What about, we have a question on you guys' thoughts on the idea of trigger criteria for referral to palliative care in heart failure patients, if that would be helpful or what that looks like.
I think it can be helpful. I think it depends on what the situation is. So if you are an inpatient team and you are trying to build relationships with cardiology, it can be helpful to develop some trigger criteria so that you're sort of helping cardiology understand when to make those referrals. And it can help you by saying approaching the team and saying oh, listen, I noticed bed 1 meets XYZ. They've had, 5 admissions this year. Would it be okay if I see this patient? So I think it can help build relationships and really get your foot in the door. But it's not always practical because you're not going to, depending on the situation, you may not be able to see all of the patients that are identified with that. So it may be a trigger to have a conversation with the team rather than a trigger like, no, you must see, there must be a PalCare consult for this patient.
Yeah, right. I mean, the key, and that you develop the trigger criteria together so that you're coming in with a shared hope for seeing certain patients, right? If we come in and you can imagine the patients that we think maybe should be seen, and the heart failure team may be like, please do not approach this patient. So making sure that it's a common ground is really important. And as Karen said, you want to sort of project what resources look like, right? Or if you're doing them, to set expectations that like we have these trigger criteria, we only have the capacity to see 3 consults a week or whatever it is, so that you can set expectations, because once they see the value, Karen's the most sought after person in the hospital. Like, it's just like once they see the value and how much benefit there is, it's hard to shut the spigot off.
Yeah. And I would add to that if you're going to develop a trigger criteria, I would frame it as a pilot. Like, we're going to try this for 2 months and see how it goes. And this is going to be our capacity to add on new consults. Yeah.
And I think we have one more question, somewhat similar vein. I think just, are there quality metrics or outcomes that institutions should track to evaluate palliative care access for heart failure patients?
That's for you.
That feels like me. That's a good question. I mean, I think it depends on sort of where. I think aligning with sort of some of the hospital priorities is important. And using those priorities to help potentially find more resources, right? I think the studies have not shown that concurrent palliative care necessarily changes length of stay or decreases hospitalization rates, or we haven't have shown evidence to show that in heart failure. And I think part of it is because of the various treatments that are offered, the unpredictable trajectory, and the acuity of symptoms that make people want to come back to the hospital where they've already experienced the benefits, right? So it's a complicated system, and we frankly have no good system to take care of people at home and avoid those problems. And so it makes sense that people come back to the hospital. But all that being said, I think in terms of quality metrics, I think from a hospital perspective, ideally, some of it may be looking, for example, like, are you seeing these people before they die in the hospital? Would be like a sort of the lower bar, right? If you're looking at people with heart failure, how many of those patients are seen by palliative care? That's like a very sort of easy to look at a marker, trying to account for unexpected deaths, I guess, within that population. Ideally, you would be thinking about looking at your population in terms of, all these patients should have a medical decision maker identified. Ideally that is happening with the primary team. That often isn't. And so, thinking about how to do education and rates, increase those rates. Things like that, I think, are appropriate. Sort of symptom assessments, I think, is a little bit harder on the broader population who are not seen by palliative care. But I think a lot of our work is really about, in the early upstream, is really about serious illness communication. So looking at quality metrics around that.
Thank you guys so much. I appreciate your time.
Thank you.
Sure. Our pleasure.